So thank you again for inviting me and for the wonderful time I've had in Antalya and in Turkey. And I have to say that the one message I go away with is the remarkable science that I've seen here being produced in Turkey, and something that I think that hopefully all of us around the world will be able to share in. So again, thank you to the organizing committee for inviting me and my colleagues from the EHPBA so that we can share with you in this. I'm going to talk to you now about common bile duct stones, but in the particular scenario of previous abdominal surgery. So I think that to talk about it in the context of previous abdominal surgery, one still has to contextualize common bile duct stones as it occurs in the general population. And we know that common bile duct stones is fairly common in patients with symptomatic cholecystolithiasis. And then there's also this issue of silent common bile duct stones that occurs in about 5 to 10% of patients. And that's become a real clinical challenge to us. It talks to routine intraoperative cholangiograms and whether they're really of benefit. But even when we do intervene in patients when we suspect common bile duct stones, we don't find stones in a significant number of patients. And then when we think we've cleared the duct, particularly after endoscopy, ERCP, there remain patients with stones. So this is not a simple subject to cover, and it's not easy to develop a single strategy to manage these patients. But I think one of the significant benefits over the last few years has been the improved imaging and our ability to get good quality MRCPs. Often MRCPs, when they're not done correctly, create more uncertainty. But today, the sensitivity and specificity of MRCP, I think, has really assisted us in non-invasive ways of diagnosing stones and managing this problem. So there are a range of options available to treat common bile duct stones. Often when we develop a strategy, we have to look at both the gallbladder and the common bile duct stone together, although that's not always the case. And when you look at it, there's what we call one-step or two-step approaches to the gallbladder and the common bile duct stones. The preoperative ERCP followed by laparoscopic cholecystectomy, I think, remains the most popular approach. Lap chole with lap common bile duct exploration, either via the cystic duct or the common bile duct, the choledochotomy, is becoming a more popular option, and I think the skills needed for that is increasing all over. And then there's unusual circumstances like the lap chole with intraoperative ERCPs, something I've never done and something I think that is quite time-consuming and actually quite a fiddle. And so I'm not sure why people would want to see that as an appropriate approach. But clearly in patients where we don't suspect common bile duct stones and then they're identified either on intraoperative cholangiogram or through postoperative clinical scenarios, then there's the postoperative ERCP that's available. If you have access to ERCP, you can ensure success by transcystically placing a stent through the ampulla ovata, making sure that ERCP will be successful. So we've got a lot of science looking at these options, a number of randomized control trials, a number of meta-analyses, and none of them have really found significant differences between any of these options when we look at duct clearance and morbidity. So the context of this discussion today is that of previous abdominal surgery. Now, when you look in the literature about previous abdominal surgery, it all falls under the context of where it's difficult or impossible to reach the ampulla ovata. And there are a number of circumstances where this happens. Most commonly, it's after gastric resections for either B2 or Roux-en-Y reconstructions. Bariatric surgery with gastric bypass is becoming, as we know, that bariatric surgery sometimes predisposes to an increased incidence of common bile to gallstones. And so with bariatric surgery, we're seeing this more commonly. And then all of us here very often do bilioenteric reconstructions after one or other operations, and often we find that we now have stones in the common bile duct or in the liver that need to be dealt with. Previous laparotomy making it difficult to get into the abdomen is another consideration, but also a number of reasons why we have pyloric or duodenal stenosis. So here the options again are endoscopic, percutaneous approaches, and and as well as direct surgical approaches, and I'm going to look through these very briefly. So when we look at endoscopic approaches and we look at ERCP, I think when Guido Costamagna has published something, it's worth having a look at it and to see what he has to say. He has an experience of way over 700 patients, which is an enormous experience of patients with the Billroth 2 gastrectomy. Only 50% of his patients had common bile duct stones, so he looked at the whole range of reasons why they may need it. The issue with the approach to these patients is that you have to intubate the afferent loop. You have to attempt selective cannulation of either the bile duct or the pancreatic duct at the time, and then perform a sphincterotomy. And this is quite difficult because you're coming at the ampulla from the opposite direction. You're coming from distal to proximal, and so all the disposables that have been developed to assist with the sphincterotomy are actually facing the wrong way. And so they've developed, and we now have all access to a sigmoid inverted sphincterotome, by which we can now do sphincterotomies either using the duodenoscope or the gastroscope if necessary to achieve intubation of the duodenum. Now, their success rate is phenomenal. The ability to cannulate the correct duct is excellent, and the ability to perform a sphincterotomy is really very good, with a very low adverse events. And the different adverse event that they find is when they go through the afferent loop, there is a small risk of perforating it, and this should never be treated conservatively, should always be treated by open surgery, and the overall mortality is extremely low. So in their view, in experienced centers, and I think that that's the most important issues in experienced centers, there is an endoscopic approach to these patients, and this can be done in their hands fairly easily. But to contrast that, this is a study that was published in Spanish, but also has a significant number of patients. And here you can see that the success rate was much lower, that they were only able to cannulate in about 52% of patients. They did have a lower incidence of common bile duct stones compared to the Costamagna study, but their ability to succeed was much lower, with failure to cannulate in a significant number of patients. The complication rate was fairly low, but still it's in these hands, and this I think reflects probably most of our experience, the ability to succeed in this situation is not as great as we would like it to be. Now, another endoscopic approach is to use double balloon enteroscopy. I think this is more commonly used when there's a Roux-en-Y limb, particularly where the limb is quite long, and it's impossible to get a duodenoscope or a gastroscope into the duodenum in a retrograde manner. So this study is one of the few studies that have recently been published comparing two approaches to this particular problem. They have looked at it comparing transhepatic approaches to the double balloon enteroscopy, and I'll discuss the transhepatic approaches in a little while, but just to talk about the double balloon enteroscopy, they had quite a good success rate with these patients, not as good as the transhepatic approach, but still very good approach, and they were able to clear the stones in most patients. The problem that I found was quite interesting here is that the recurrence rate of stones, and that patients did redevelop stones in many of this in the study, and I'm not quite sure I understand the reason why. So let's look at the percutaneous approaches. The main advantage of the percutaneous approach is the ability to target a particular segment of the liver, as you all know. And so if you're dealing particularly with intrahepatic stones in this situation, the percutaneous approach becomes particularly attractive. But it does have significant technical disadvantages. It requires multiple steps. You have to go in and out with guide wires and then dilating catheters and then catheters through which you work. And all of that adds to the risks of this procedure. When there are intrahepatic stones and they're in multiple segments, you can't get to them as you may be able to from the ampulla ovata. There's exposure of the operator to radiation. And clearly in patients with coagulopathies or ascites, this approach is contraindicated. Now, we've been doing this for many years. Traditionally, it was done with small balloons, so we were using less than 10 millimeter diameter balloons to dilate the ampulla ovata. Recently, there's been the addition of percutaneous cholangioscopy, which seems to have added a lot to the success rate of these procedures. But they have the usual complications of cholangitis, biliary pleural effusions if the catheter is placed through the pleural space first. And I think that anyone who's seen patients with this will know that the hemobilia is far more common, but it's usually self-limiting and usually stops very soon after the procedure, but sometimes has been known to continue, and sometimes we've needed angiography and embolization to block an artery that is being punctured during the procedure. So this study, again, I have to say that most of the studies that I've been able to look at in the context have had large numbers but have been single center or cohort studies, making the level of evidence not great. But certainly in this study, again, large number of patients, good success rate, and very low complication rates in this procedure using percutaneous approaches. Now, here's a study where they recently used a much larger diameter balloon. And so while using a 10 millimeter balloon was easy, if you had a stone that was 15 millimeters or 12 millimeters, balloon dilating to 12 made the procedure quite fiddlesome. And so using a larger balloon, being able to dilate the ampulla to 15 millimeters or more seemed attractive. But the evidence, certainly endoscopically, of whether that was safe to do without an endoscopic sphincterotomy has not been clear. And so the issue here will always be around the risk for pancreatitis. So they were able to do this procedure with a very low level of complications, and of note, the pancreatitis rate in this series was quite low at 1.4%. But the recurrence rate, or missed stones, is significantly high. And again, that was of concern to me when looking at this particular approach. So how about the addition of cholangioscopy? Now, the technology around cholangioscopy has developed quite significantly. We use the spyglass that we normally use endoscopically, but we can use that through very small 7 or 10 French catheters into the liver. We can identify the stones, and we can then manage the stones in a number of ways. So in this particular study, they needed to do it in 7 or just under 10% of patients who had common bile duct stones where they had failed in other approaches. But it was quite a good option, and the indications were in this series were about half the patients had post-gastrectomies in the context that we're just talking about now. But their ability to remove stones was 100%. But this is what makes this approach a little bit more challenging, because it requires two approaches. And in this table here, the top bit talks about the complications of the initial PTBD, the actual percutaneous biliary drainage. Because then you have to wait for the tract to mature, and this can take 2 or 3 weeks, and then you go back with your cholangioscope, sometimes having to balloon dilate, sometimes just be able to use catheters to get into the liver. And so you have complications at both stages of the procedure. Although this looks quite high, the major complication rate was quite low, and I think that it's become a real attractive option to the approach to these patients without access to the ampulla ovata. So how do we actually break the stones in these patients? Well, there's the whole range of options that we have and that we've always had, and that's really looking at mechanical lithotripsy, looking at laser lithotripsy. And so if you're using the electrohydraulic lithotripter, which is a mechanical lithotripter, you're able to get quite good fragmentation of the stone, but unfortunately this approach seems to have a significant complication rate. And so we prefer to look at other techniques, particularly the laser techniques. We've been using the Freddy laser for a while now with great success, but through the cholangioscope there's also now the ability to use a whole range of lasers which are very effective in fragmenting stones and achieving common bile duct clearance. Now, when I was looking through the literature, I came across this study and thought this was quite fascinating, presented earlier this year, because this study suggests that you can use the transhepatic approach to clear stones in the common bile duct and in the gallbladder. And particularly in older patients where you don't want to actually do anything about the gallbladder, going through the cystic duct, through the common bile duct into the cystic duct, balloon dilating the cystic duct and removing the stones or fragmenting the stones seems to be an attractive option. This study only produced one case, but did look at the literature around it. And again, the issue is about whether this gives you an increased risk of cholecystitis or even pancreatitis. So balloon dilatation, I think, is safe. As I indicated earlier with sphincterotomies, we know it's safe. We weren't quite sure what the impact would be without sphincterotomy, and that seems to be okay using larger balloon diameters. But it can be quite tedious to do it transhepatically, but if you've got no other option, I think it's an attractive approach. And when you look at this comparative study, looking at the transhepatic approaches, either just with drainage or using the cholangioscope, comparing it to endoscopy, the big issue here for me, and we've heard that from Thomas van Gulik when he was talking about the trial from the AMC that was stopped because of high incidence of complications after PTBD, and this study seems to confirm that with a much higher complication rate using the percutaneous approach than with the endoscopic approach. So when your back is against the wall and you don't have any other approaches, I think this is a valuable adjunct, but I think one has to be aware that it does cause significant complications. So this is just a big stone in the common bile duct, a big balloon, and then being able to clear the duct. This was an interesting patient of mine who developed a post-ERCP bile leak, which didn't settle, and we couldn't understand why. This is a patient who had previous surgery for obesity, and you can see on this, you can see the complex nature of the bowel, but we were able to put in the balloon, dilate it up, and clear the biliary tree. So when necessary, this certainly in the right hands with the right skills is an important approach. But I think as surgeons, the question for me is, well, where does laparoscopic common bile duct exploration fit in? And many of these patients have had their surgery done laparoscopically, particularly when it's metabolic bariatric surgery. But some of them have also had Whipples and other such operations, making it very difficult to access surgically the porta hepatis. But I think it's still something that we should be considering, either transcystic or transduodenal. And when you look at it in all comers, the success rate is really good with a fairly low complication rate. So I've mentioned that there's the 2 or 1 stage procedure. And so what is the value and the benefit of doing it? If we can achieve this endoscopically using Costamagno's approach, or we can do it laparoscopically, we're still faced with the theoretical advantage of leaving the sphincter of body intact, which avoids the duodenal biliary reflux, it avoids the ERCP complications, it avoids the potential endoscopic sphincterotomy stenosis, and it avoids metaplasia of the bile duct. And the outcomes that have been looked at in both meta-analyses and Cochrane reviews, systematic reviews, are looking at all the same issues that we've been talking about so far. And here are the two reviews. There was one in 2013 and one in 2012 and one in 2013, comparing the option of laparoscopic common bile duct exploration with a whole range of other options. And in all of them, there was no difference in the outcomes, whether you looked at stone clearance, morbidity, or mortality, conversion rate, length of stay. Total operating time was clearly longer when you did it via the common bile duct. So it all depends, and all these studies, the issues are a routine practice in a center, so whether you're doing ERCP routinely, it's sometimes difficult to break that habit. The skills available, because lap common bile duct exploration is not something general surgeons should be doing. The availability of adequate equipment, and then a multidisciplinary approach to make the decisions. But all these studies don't talk to these issues: what to do with bigger stones, what to do when you have a number of stones, how does the size of the duct impact on what we do, whether previous ERCP has been done or doesn't, does that make the success rate higher or lower. But the one that is relevant here is there's no discussion about the role in previous abdominal surgery. So just very briefly, the techniques are either transcystic, transductal, and then there's the second question, which is the issue around the primary closure or using the T-tube, and I want to just talk very briefly about these issues. So the indication for the transcystic approach, although not absolutely defined, seems to be suggested that smaller stones are best approached that way, if there's a small number of stones, and if the stones are distal to the cystic duct junction, it seems to be a really attractive approach. But doing a koledocotomy is a much more difficult operation, but it's available when the common bile duct is more dilated, when the stones are greater than the size of the cystic duct, when there are a large number of stones, when there's a very low insertion or medial insertion of the cystic duct, or when there are intrahepatic or common hepatic duct stones. So this is a patient. Can you just briefly start the video for me, please? This is a patient that had had previous surgery, and you can see that the wall is very thickened. It's not easy to get into the common bile duct to do the koledocotomy, but yet it's certainly possible. It takes a bit longer. One has to be a bit more cautious, but it's certainly possible to get into the common bile duct in this situation and to remove the stones. So what about the transcystic or the transductal approach? And if we compare that to ERCP, and this was an interesting study published a few years ago, where it clearly showed that ERCP and the transcystic approach were fairly similar in terms of bile leaks, in terms of morbidity, but the transductal approach certainly was a lot more difficult and resulted in a lot more morbidity and bile leaks. This, again, is a study that I think we're probably all aware of because it's really influenced our treatment, and most of us don't use T-tubes any longer in this scenario, and we go for primary duct closure. And we know that primary duct closure in this situation is safe and does not lead to a greater incidence of morbidity. And in fact, some of these studies suggest that it gives a lower incidence if you do primary closure. There's a lower morbidity than if you're using T-tubes. So after covering this whole scenario, I'm afraid I don't have a very strong answer to you about the best approach. I think the best I can hope to have offered you is to tell you that these approaches do exist. There's limited data in the literature to compare them and to show which one is better than the other. I think each one of these has been established in their own right in the non-previous abdominal surgery scenario, and when they are adapted to the particular scenario we're talking about, I think that there's no evidence that they are worse. So there's no strong evidence to support one or the other. And so I think the main issue is the available skills. As long as your gastroenterologists are on board with you and having the conversation with you about what approach is best in the individual patient, I'm sure the right decisions will be made. But it is technologically very dependent. Whether you're looking at cholangioscopy, whether you're looking at double balloon enteroscopy, whether you're looking at specific types of sphincterotomes, all of them require a different approach, and on those, that kind of equipment is not routinely available in every unit. And when you are going to use this, there is a need for advanced expertise. And I think the outcome from Costa Mania compared to the Spanish group definitely shows that when the skills are superior, anything's possible. But when you're average, like the majority of us, then I think that one has to be aware that you need to look at different options. So my final comments would be that minimally invasive approaches are available in this complex scenario and should be sought. But I think I do need to say this, is that while we talk about this advanced technology, the evidence comparing open common bile duct exploration to laparoscopic common bile duct exploration definitely suggested that laparoscopic common bile duct exploration open still has a role to play. And in fact, if you look at the outcomes, while they are all old studies, the outcomes are fairly similar to laparoscopic. And if you're unable or you don't have that access, I do think that open surgery still remains a good and viable option in these patients. So thank you for your time and thanks for the opportunity to talk. Thank you.